and to talk about it. But certainly there are some brain factors in terms of the changes in the brain metabolism for neurotransmitters, and also with neuropeptides. And we talk about white matter hyperintensities, and also reduced in cerebral blood flow to a certain part of the brain where mood is regulated, like the prefrontal lobe, the limbic areas, particularly the anterior ungulate region. Now, this is just to tell you that the neurotransmitter changes, this is age-related, and therefore that may increase the vulnerability of an older person of developing depression. Now, I think we talked a bit about vascular depression just now, and one way to define it is by neuropsychological profiling. So they have a typical profile where the predominant disturbance is that of the executive function. So a neuropsychological assessment will elicit through the appropriate test the deficits in terms of executive dysfunction. The other way is, probably more interesting way, is through the MRI, where you can actually see a lot of white matter hyperintensities. But the two are together very much correlated to the Framingham vascular risk factors. And we know that all these vascular diseases appear to contribute to late life depression by affecting, just now Tommy talked about the circuitry between the limbic, the cortex, the subcortical region, and particularly the cortex in terms of the frontal lobe for mood regulation. So these white matter changes, probably is vascular in nature, would then predispose somebody of developing a depression, and therefore the concept of vascular depression take roots as a result. Now, the physical illness is very important, and I think compared to depression in younger person, you know that these are the list of, this is by no means exhaustive, but these are some of the conditions that certainly can predispose somebody of developing depression. And other than disease, I think I mentioned earlier on, is the disability, right? If you have stroke, but you recovered, or you have stroke and you became more disabled, the disability is one of the mechanisms by which it increases the vulnerability of somebody of developing depression. And we know that depression and medical problems frequently coexist, okay? And the causative pathway is probably bidirectional. So, a stroke can cause depression. Depression can increase the risk of stroke, for example. Now, from one of the survey studies have reported that depression actually increases the disability, ADL disability, as well as the mobility disability by a significant percentage from this prospective studies. So in other words, depression can independently increase the disability. Now, again, the mechanism, I think Fong Yin talked about it being complex, not well understood. And one of the examples that I've managed to find out is to link depression and myocardial infarction. And this is what they have found, that there is a certain specific type of polymorphism in the serotonin transporter link promoter region. And this is then associated with a higher level of platelet aggregation and beta thromboglobulin, which in turn then increases the risk of myocardial infarct. So things like this would sort of give you some glimpse about what are the possible biological mechanisms by which depression is linked to a physical medical condition like a myocardial infarct. Now, in terms of depression and mortality, just now we mentioned about increased mortality, but there are some studies that showed there is no increase in mortality if you control for medical illness burden. So in other words, if you correct and control for medical disease burden, depression itself doesn't increase the mortality of the person. But yet, there are also some studies, older studies perhaps, found that even when you control for this, there is still an increase in mortality. Now, in terms of nutrition, I talk about B12 and folate. Again, some studies have reported a low folate level, a low B12 level. So they are not important just for risk factors for cognitive problem, but also for depression. And you know that a lot of elderly actually suffers from low B12, and giving them oral replacement may or may not help, because if they have pernicious anemia, if they have antiparietal cell antibodies or low-level intrinsic factors, your oral replacement would not work, in which case they would need intramuscular replacement 3 monthly, for example. So I have begun to look at my depressed patient and I'll start to take their blood for B12 and folate. Now, drug, I think this is something that you are aware of. Now, the psychological factors, just now we talked broadly about personality traits. Now, what does the literature report? I think someone mentioned about being neurotic and also cluster C and cluster B. Neuroticism, cognitive distortions, a sense of external locus of control would increase, associated with increased depressive symptoms. Whereas a higher level, a sense of mastery or a sense of self-efficacy are associated with lower depressive symptoms. Protective factors will be, someone mentioned about religion. There's a lot of studies about association of spirituality and religiosity with either lower depressive scores or better response to treatment. And I think we have our mental image of elderly being pathetic, in a wheelchair, suffers lots of pain and disability, and therefore they are at risk of developing depression. But on the whole, I mean, there are also a lot of reports done to show that a lot of elderly have that ability to be protected against depression. So some people have used the term psychological immunization, where they, over the years, because of the experience that they have gained, they are more stoic, they have wisdom, they are better impulse control, unless they have got cognitive impairment compared to the younger cohort. And there are also some studies that shows that they need less mental health consult to produce the same amount of improvement compared to the younger cohort. So I think our idea of older person, older adult, doesn't mean that they are like so frail, they are so vulnerable. There are some protective elements that some older adults have that can actually help them to weather against the onslaught of depressive illness. Talk about the religion and religiosity. And the work of Harold Koenig is quite interesting. If you have time, you should go and read his publications. I think social event is intuitive. We all understand that you have bereavement, you have all sorts of life events that has a meaning of loss, whether it's a life-threatening illness of someone else other than the person, housing issue, family relationship issue, as the code red video has shown. Retirement can be stressful, can be a precipitant of depression. Social isolation certainly is very important. Chronic social difficulties. So things like social support, and sometimes it's the perceived social support. Because I don't know about you, because some families seems quite supportive, but to the person with depression, they feel that they're not supporting. They're not supportive. They are there but not there, that kind of thing. So the person's perception of the kind of support that he received may also be a factor towards whether he is at risk of developing depression or not. So we talk about social, economic status and lower education being both also at risk factors. I think we have seen this in different contexts. So these are some of the different presentations that an older person can come to your clinic, and instead of just saying that I have depression, these are the different possibilities that we should be aware of. And I think we have covered this quite a bit just now. I think I'll skip this. Now, I think this one also has been adequately covered, so I will just give it a miss. Now, what is important, I want to stress, is that in the past, we used to think about pseudo-dementia as being fairly benign, so that when your depression is treated, your cognitive problems would reverse completely. Now, usually, if that's the case, indeed, that if you treat the depression, their cognition will improve. But studies have also reported that a lot of them, the improvement is not complete, even though the mood has improved. And this group of people are actually at risk of developing dementia later on. I don't know what, I think I've given you the Framingham Heart Study, and I think that's a very interesting paper that talks about how depression being a risk factor for developing dementia in general, as well as Alzheimer's disease in particular.